Okay, thank you everyone for joining us for today's Benefits Buzz, Making the Leap. What is value-based care in the employee benefits ecosystem? We're going to go ahead and jump right into today's presentation. But before we kick things off, please note, this event will be recorded and we will share the recording in a follow-up email sometime early next week. And if you have any questions, please feel free to drop them into the Q&A and we'll do our best to get to them at the end. I am pleased to introduce you to today's speaker, Elena Gambon, Chief Strategy Officer and Chief Growth Officer at First Up Health. Elena, would you like to take a moment to introduce yourself?
Sure.
And
you all have just met my cat. Hi, everyone. Elena Gambon here, Chief Growth Officer and Strategy Officer. I am so excited to be talking about today's topic. It's a very interesting one because I think when people hear the words value-based, they either think, well, that's a buzzword and I have no idea what it actually means, or they think, you know, that's really more of a Medicare, Medicaid thing, which is fair because the bulk of value-based contracts have historically lived in the government payer space. And people often wonder how it could apply to a commercial benefits or an employee benefits strategy. So what I'm hoping we can do together today in 20 minutes is start to clarify what value-based can mean and should mean, and specifically what it means in the context of employee benefits. So first, as we always do, I want to start off by reminding you all who know us and introducing you who don't know us, who First Up Health is. We are a direct virtual care company serving over 1,000 and actually today 1 million members nationwide. Our solutions span the spectrum of physical and behavioral health, and we serve clients across all industries, all sizes, all funding structures, all populations, from medically enrolled to part-time. The solutions that we offer are virtual urgent care, which is 24/7 telemedicine, access to a doctor in minutes for triage and prescribing. Primary care, which is scheduled visits as soon as next day with a primary care physician who spends time with you and listens to you and is supported by a full suite of navigation and care coordination. And mental health, which is short-term focused counseling for things like anxiety, stress, and depression, long-term counseling coming 1/1 of 2025. And the thing I always like to say is what we do better than any other virtual care company in this market is achieve extremely high levels of utilization. We believe so firmly that that utilization is really the pinnacle of what we do that we contractually guarantee it at a rate of 30%. But on average, our clients are seeing 60% utilization. That actually, believe it or not, is a perfect segue into where we're going to start in this value-based conversation, and that is with the definition. So anybody that's ever written a research paper knows that before you dig into a meaty topic, you work to define. Value-based has really kind of been nebulous. And so we're going to use the definition that the Centers for Medicaid and Medicare Services uses, CMS. The first thing that they say value-based care is that it is care that is delivered in an ecosystem where payment is tied to quality and outcomes. Typically, this involves a discrete or contained population for which a payer and provider are responsible, and that responsibility involves high accountability around improvement in population health metrics over time. The second pillar of value-based care is that patient experience is at the forefront of the care engine. So this means simplifying access to care, often deploying technology and data to inform improvements, and individualizing or personalizing this care. And this is really where we start to walk into the world of social determinants, health equity, making sure that the care that is delivered is not equal but equitable, and there is a difference. And then the last pillar of value-based care is around provider performance, specifically the continual assessment of the provider performance and the creation of a care team that is not one-dimensional, a care team that supports not just interactions with doctors, but also nurses and case managers and patient advocates and everything that you need to reduce the fragmentation that exists in our healthcare system today. Now, in many ways, most value-based care in the employee benefits environment, which is a pretty competitive market, unlike the government payer market, has revolved around altering the fundamental plan structure in which care is provided. And so what I mean by that, or some examples of that, are employers will create bundled payment or direct contracts with centers of excellence. That's a form of value-based care. Employers will carve out certain components of coverage, like prescriptions. That's a form of value-based care. Employers will partner with carriers that have very specific, narrowed, or tiered network plan designs. And sometimes they'll even go one step further, and they won't just incentivize the providers, but they'll actually incentivize the employees to engage. And that's a value-based benefit design. Now, we believe, and we'll show you in just a second here, that First Off Health, which is not in and of itself a health plan, but rather partners with any employer in a direct care capacity, is also one of the ways that you can create a value-based ecosystem for employees. So let's talk about that specifically. So these pillars that you just learned about can be applied to things that we do specifically. So on the quality and outcomes pillar, again, remember this is payment tied to outcomes. We contractually guarantee what we believe is one of the most important outcomes, which is utilization or savings. And we have a capitated PEPM, which means both in terms of our revenue structure as well as our guarantees, we are getting paid on value, not volume. Second, we pay very close attention, not only to the clinical protocol that we are delivering on, but also the reporting of that clinical protocol. So we have an emphasis on transparency when it comes to population health improvements. And I'll give you an example of that in a minute. On the second pillar, from patient experience perspective, this is why we were born and founded. So not only do we have a diversity, equity, inclusion, and belonging focus when it comes to hiring and training our providers, we serve the patients where they pay $0 for care, eliminating financial barriers. There is 24/7 access with a particular eye for off-hour and weekend support, because not all people have the same type of job. We deploy motivational interviewing when we're talking with patients, actually spending time with them, especially in the primary care and the mental health environment. And through our engagement and also our clinical protocol, we emphasize proactivity and concern. Our tagline is care that people love. And love is the emotion that we try to give to and also hopefully invoke for our patients. On the last pillar of provider performance, this takes a couple of different forms. So number one, we do employ a care team approach. So our doctors are paired with nurses and coaches and case managers so that a patient isn't just having a visit with a primary care physician and getting a prescription or an MRI order, but actually having their hand held when it comes to finding the best place that is in network and the lowest cost for them to do that. We also deploy rigorous quality assurance protocols when it comes to assessing the care teams that we have. And those care teams, as I just mentioned, are really one piece of the puzzle when it comes to treating a patient and sort of the whole person experience. So we can actually go one layer deeper, specifically talking about our primary care. If you'll flip to the next slide and then one other. And understanding how is our value-based primary care different from traditional fee-for-service primary care? So let's take a look at the opposite of value-based primary care, which is fee-for-service payments tied to relative value units, or RVUs, which reflects discrete amounts of work done by a provider. Many attributes of fee-for-service primary care and the relative reimbursement rates set by CMS are some of the issues that have promoted this idea that primary care is one of the lowest reimbursed specialties. And that actually propagates a shortage of primary care physicians and larger patient panels and primary care physicians having to sell to hospitals to stay afloat. And so in many ways, the fact that primary care is fee-for-service creates some of the issues that we see in it today, which is limited amount of care coordination, reactivity, not proactivity, an increase in patient volume, which means less time with every single patient, and participation in a hospital system, which can have value, but unfortunately often just results in misaligned incentives around referrals, referring someone back into the hospital system rather than having an agnostic approach to cost and quality and network status. And you can see both in some of the data that we've run and also probably from your own experience that this results often in a poor patient experience. Now, I will say we love primary care physicians around here, and most of them are doing amazing work, but the structure is failing them. So an alternative on the next slide is what a value-based primary care solution looks like. And this is one where providers are paid on outcomes or time spent, not number of patients they see, where First Stop Health is accountable for the success of the program in the utilization guarantee, where we deploy full care coordination and a multi-specialty team, not just a 7-minute visit with a primary care physician when it comes to treating a patient, and where we rely on our proactivity, outbound engagement, creative incentive structures, so that we can ensure people are not only using the solution, but they are using it at the right time and the right people are using it. We want to create new healthy behaviors and look at the population as a whole and understand what percentage of patients are we actually interacting with that we're completely avoiding care, or we're using ERs instead of seeking care from a relationship provider. And so what we're able to do in this environment is pretty dramatically change some of these statistics that you saw on the last slide. We have a plus 96 net promoter score in our primary care environment, average 72% utilization for clients who have primary care and often partner it with mental health, 26% lower costing care paths, and our patients pay nothing, which means they are at no risk for just trying it or starting a relationship. And sometimes that activation threshold is, that's all you need to get someone to engage. So if we reorient this back in terms of these pillars, and again, I'll go one layer deeper, starting with the quality and outcomes pillar. I mentioned that this is based on payment for value and having clean and crisp clinical policy. And so in addition to the 30% utilization guarantee that we provide and the population health reporting that shows the percentage of colonoscopies we were able to help a patient complete, or the reduction in BMI of a population, or the improvements in A1C for diabetic populations within an employer, we are also building clinical protocol around every indication we might see. So this one is an example for you around diabetes. Every patient starts with sort of a baseline of, really, it's just patient understanding, risk identification, whether we need to capture baseline diagnostics if they haven't been captured before, or review previous diagnostics that a patient has had, talk about symptoms, patient perception. From there, we move into a shared decision-making protocol, which is really around spending time with the patient and understanding their perception of barriers to care, because that matters more than almost anything else. And then creating a checklist and the adherence support so that a patient isn't just given a list of things they need to do and seen again next year, but has routine touch points with our care team that might include durable medical equipment or benefit support when it comes to getting coverage, or securing a good pathway towards regularly checking their own vitals or their own staff. When it comes to the second pillar of patient experience, we like to think about this not only in terms of being a one-stop shop for care, if you'll go to the next slide, and creating an environment where any patient can come to us regardless of what they think they need or they don't know they need, and we can get them to the right place, but also creating an environment of accessibility. We've already talked about the $0 fee for patients. We do not require that patients register. Everyone comes pre-registered. When they decide they want care, they're talking to a doctor in minutes or days instead of waiting weeks or months. Those doctors are multilingual. Patients can use our technology or always just talk to a person via the phone. There is support for the whole household, not just the employee. So it is the detail of the human experience that makes the difference here. And it is the hand-holding after that patient engages with us that helps them create a better, healthy path. And then this last pillar around provider performance, I really want to focus here on the care team. So if you'll flip to the next slide, these are some of the things that our care team does. Not just a 30-minute visit with a primary care physician talking about your health. It's steerage to the other benefits available to an employee, in-network referrals, benefit and bill questions, clinical guidance that might complement what the provider says. Because sometimes patients leave a primary care visit and they have questions, or they want to talk again the next day. And maybe that's with their primary care physician, or maybe it's with their nurse who they're getting to know. As well as this follow-up and proactive support around closing gaps in care. And this care is delivered from our nurses, our advocates, our doctors, and our health coaches across the spectrum. So hopefully what we've done today is giving you some tangible bites around this very nebulous concept, which is you can create a value-based arrangement in an employee benefits package. And it doesn't have to mean that you are creating this really robust, accountable care organization in partnership with Medicare or Medicaid. It can mean looking at your benefit structure and identifying either ways to change it or add to it that adhere to the principles of those three pillars that we talked about today.
Elena, thank you so much as always for such an incredible presentation. We did have one question come into the chat, and that is, how do we ensure the quality of specialists that are being referred?
That's a good question. Like any good value-based organization, it is coming from a lot of data. So we partner with a number of entities that provide us with steerage and transparency around providers using claims. So we leverage about 14 billion price points of claims data that looks at not just individual allowed amounts of services that we're recommending, but also clinical patterns like procedure volume, complication rates, patterns around prescribing. There is so much that you can glean about a doctor from how they've historically performed and been reimbursed. And then on top of that, we layer on the human element of who does a patient want to see, how close to their home or work are they available within the next week, do they speak their language? Sometimes that matters more to actually get a patient to go. But if we don't do the research on the back end around in-network status, cost, and quality, there's very little that a patient has to arm themselves with that information. And so we owe it to them to support them that way.
Great. Thank you so much. It looks like that was our only question for today. I invite everybody to join us at our next Benefits Buzzes, and we will be releasing April and May topics in the coming weeks, so be sure to join us. Thank you again, Elena, for just a great presentation, and thank you to everyone for joining us, and I hope you have a wonderful rest of your day.
Good one.